Good morning. I'm Dr. Sean Coomer, Chief Medical Officer for the Kansas City Division of the University of Kansas Health System. I'm back for another edition of Open Mics. Dr. Stites has the day off, and we're going to give him a few days to rest after that as well. Today we're talking about something that's in my wheelhouse, kidney transplants. When your kidneys are diseased or failing, it can trigger a lot of different symptoms. One in particular you might not expect, as you'll learn from our patient today. Also joining us is my colleague here at the desk, Dr. Aditi Gupta. She is a transplant nephrologist here at the health system, which means some patients on my operating table are also her patients. Dr. Gupta is also a scientist and researcher here at the University of Kansas Medical Center and a first author for a recently published study that offers great insight into our topic today. Thanks for being here, Dr. Gupta. Appreciate that.
Thanks for having me.
A little bit later, we'll be checking in with Doc Hawk to ask about a newly reported bird flu case in the state of Missouri. And as always, we'll be answering your questions in the chat. But today we'll start by hearing directly from a patient. Alexis Del Cid introduced us to someone who knew her brain wasn't working like it should, but had no idea that her kidneys were actually to blame.
For Tammy Bunny, playing the piano comes as naturally as breathing.
I've been playing all my life.
The Garden City woman learned how to play at age 7.
Both of my parents were musical, and so my mom played all the time.
She went on to major in piano in college, teach piano to grade school children, play at various special events, community centers, and at church every Sunday.
I play the old-time hymns.
Music is Tammy's life, so you can imagine how scary it was when one day Tammy suddenly forgot how to play.
I was playing for a funeral, and I could see the music. I knew what the notes were, but I felt like I wasn't all there. But the brain just didn't react. It was really weird.
Next, she forgot how to lead the meetings in a club she'd been active in for years.
I could not remember. I knew what it was supposed to be. The brain just wouldn't function. And afterwards, people say, "What's wrong with Tammy anyway?"
What was wrong with Tammy?
I've done all this stuff all my life. Then all of a sudden, it just wasn't there.
Next, she noticed a change in her eyes.
My eyes were not bright. It just kind of like dull.
She felt like a stranger to herself, and to make it worse, she was also suffering terrible kidney problems, which dominated her doctor's visits.
I didn't have enough presence of mind to tell them that my brain wasn't working that well either.
What Tammy didn't know at the time was her kidney problems were causing the brain fog. It was all tied together, and a transplant could give back her sharper mind. How? Researchers at the University of Kansas Medical Center say cognitive impairment is often associated with advanced kidney disease because the disease can cause a buildup of waste products in the blood, affecting brain health. Tammy was finally referred to the University of Kansas Health System, and on May 1st, 2024, she got her new kidney. And when Tammy returned to Garden City, she noticed something amazing. All of her brain fog had disappeared. She could play again.
I could see the music. I could understand the music. I knew what the notes were. I knew where my hands were to go. I knew what I was playing. I didn't have to think.
Well, that's really amazing. Wonderful music you're playing there. In Tammy's case, a new kidney cleared up her brain fog. Amazing. What a kidney has something to do with the brain? Obviously, the kidney is sometimes referred to as the abdominal brain, but doing a lot of things. But can you explain to us how a diseased kidney can impact the brain?
Yeah, I love the phrase abdominal brain. So yeah, the kidney, as you might know, is the kidneys filter the blood. So as our body works, the cells work, they make a lot of waste products or toxins. And the job of the kidneys is to filter out those toxins. When the kidney function is not so good, then those toxins start building up in the blood. Now you would say, well, they're in the blood. What about the brain? So we have something called a blood-brain barrier, which is made up of cells and some channels, and it protects our brain from these toxins. But in kidney disease, this blood-brain barrier gets disrupted. So some of these toxins in the blood can actually move on into the brain and cause some problems there. In addition, people with kidney disease also have other risk factors for cognitive impairment, like diabetes, hypertension, which can also cause some brain injury. In fact, our group was one of the first groups, or actually one of the only groups right now, to show that there's disruption of the blood-brain barrier in people with kidney disease.
That's interesting. So when we assess if someone's a candidate for kidney transplant, how does their brain health enter into that discussion?
Very good question. So we're talking about a kidney transplant, so why are we talking about the brain? Well, so as you know, transplant, there's a lot which goes into transplant. There's shortage of organs, and when we transplant somebody, we want to make sure that this kidney is doing well for them and they get full benefit of the kidney. But if people are not taking their medications or are not able to follow instructions, then they could lose their kidney. So we don't want that to happen. So sometimes we wonder if brain health can impact their ability to follow instructions. So then it becomes a big issue, but we have to remember we are seeing them before transplant, and what they are before transplant may not hold true after transplant. And that's a tricky one. We don't have a crystal ball there.
Right. So, first of all, you are a busy researcher. Congratulations on your funding and your publications. But you led a study recently that looked at changes in cognitive function after kidney transplant. It was published in the American Journal of Kidney Diseases. What prompted you to explore this connection between the kidney and the brain?
So this study was actually inspired by our patients. So, we are rewinding back to like 12 years ago in the clinic. I saw patients and they said, "Hey doc, thank you for the transplant. I don't have the brain fog anymore." And I was like, "Oh, wait a minute, we just did we did a kidney transplant. Why are you talking about the brain here?" But then with that, I started asking other patients, and looks like this was a common phenomenon, but as a nephrologist or as a surgeon, we generally don't talk about the brain fog. So I started, talking to everybody, and I was like, okay, this needs to be studied. So that's how the study originated. There was one major problem. I was not a researcher then. So I had to do a master's in clinical research to get there. But then eventually we said, okay, let's do this. Let's enroll people who are on the transplant list, follow them through their transplant, and then assess them before transplant, and then assess them after transplant. So we looked at cognitive function before transplant. We also did a brain MRI before transplant to see if there's any change in cognition. Is it supported by some actual changes in the brain, which we can see? And then we tested them again 3 months after transplant, and then 1 year after transplant.
Right. So can you give us a brief overview of how you structured the study a little bit more, in more detail, and how many people you followed during that study?
Yeah, so it was a challenging study because we don't know when a kidney is available for a patient. We don't know when the transplant's going to happen. In a very, if you want to do the study the best way, you should say, okay, we check then 3 months before the transplant, but again, we don't know when the transplant's going to happen. So so we enrolled people. Some of them did not get a transplant as expected. So we repeated assessment a year after their enrollment, just to make sure that their assessment is not too far away from their actual transplant date. And then we checked a lot of things during the pre-transplant assessment. We looked at depression, cognitive function, brain MRI, physical activity. Towards the end, we also looked at smell, because smell and cognition are tied together. And then, most of them got transplanted. We had 101 patients. This study spanned the COVID times too, so it was hard. Transplant numbers, it was tricky to do transplants back then, if you remember. And then some of the patients, we just told them, if you don't feel safe coming for a visit, that's okay. So some people missed the 3-month visit, some people missed the 1-year visit, but eventually we had a very good follow-up, and about more than 90 of our patients actually had at least one post-transplant visit.
The viewers are looking now here at your study outline right there, and so thanks for explaining that. So cognitive function is not just one thing. How did you measure someone's brain health?
Yeah, very interesting question. So cognitive function, the way we measure it, I should say cognitive performance. It's paper, pencil test, it's question and answers, and people answer them. So there's a little bit of, I would say, maybe a little bit subjectivity. So we also looked at brain health with MRIs. So we looked at brain blood flow. We looked at, it's called diffusion tensor imaging. Basically what it measures is that if your nerve track is intact or not. So generally water molecules kind of travel in one direction in the nerve tract. If they go here and there, that means there's a problem in the integrity of the nerve tract. So we looked at that, and we looked at some neurochemicals in the brain. And all these findings, they were different before transplant, and they all kind of normalized, went more towards normal after transplant.
Great. So what were your results? I think we have a graph that you can kind of describe here for us. It's on the screen.
Yeah, sorry about the busy graph here, but so these three graphs, they showed three different tests of cognition. So I'll start with the first one. So that's logical memory. So it's basically kind of a recall test. And the blue line is pre-transplant. The black line, which is very close to the orange line, is normal. And then the orange is post-transplant. Lower the line, that means lower scores, which means bad. Higher scores are better. On the x-axis, you can see age. So you can see how, with age, there is an age-associated change in cognitive function. So you can see that line trending down, all three lines trending down. And that's maintained even with kidney disease and post-transplant. But you can see the big difference between pre-transplant and normal and post-transplant. So there was a lower score for logical memory before transplant, which normalized after transplant. And those little dots and those lines are individual patient trajectories. So you can follow each line. The blue one is pre-transplant, and the orange one, since we have two post-transplant visits, they are post-transplant visit at 3 months and then at 1 year. And you can see most of the orange dots are above the blue. Some of them are not, but most of them are.
So you can't, I guess I'm interpreting this as you can't really escape the age association decline, but you can get improvement after a kidney transplant in this case.
Exactly.
Okay. And I think we have another graph here, if you could kind of explain that, the results here, what these mean.
Yeah, so our results are in a way threefold. First is we looked at what's happening to people with kidney disease. So this is the pre-transplant assessment. And these rectangular boxes, they are the different tests for cognition, which we did. So the first, column, pre-transplant versus normative data, it shows where these tests people did not perform as well in these tests. So the downward arrow means that pre-transplant patients did not do as well as the normative data. And then digital span and trail making, they did fine. There was no deficit in those two tests. And then the last column, it compares the pre-transplant and the post-transplant folks, or actually the same people, but their post-transplant status. And you can see that some of the tests actually improved. So the upward pointing arrows mean improvement in in that particular test. And some of them did not change. Some other studies have shown that trail making is also affected in kidney disease. Our study did not show that. Partly, I think we had a very high level of education in our patients, so that might have contributed to that difference.
Well, interesting. Does it make you play the piano better?
I wish I could. That's why we have Tammy.
That's right. So what should a patient or the loved one take away from this study?
Lots of things, but I would start with, transplant is the treatment of choice. I think most people know that. But if you have kidney disease, and if it is severe kidney disease, I would say talk to your doctor about potentially getting a transplant. Some things which are associated with kidney disease, like brain health, do improve after transplant. And we're talking about brain health, but there are other things, quality of life, depression, they also improve after transplant.
Okay. So what advice would you give to other healthcare providers that might be practicing and not directly involved in transplant nephrology like yourself?
Yeah, so knowing the fact, so when I was a training resident fellow, everybody would say, well, patients with kidney disease, they don't take their medications, they're non-adherent. But I think we have to understand that this non-adherence may not be them, it might be the kidney disease affecting their brain health. So keeping that in mind when we talk to our patients with kidney disease, maybe helping them with the instructions, repeating the instructions, giving them written instructions, clear instructions, maybe not putting too much like information overload, maybe just emphasize on the main points and go with that. So maybe just the way of delivery of our instructions and educations with patients with kidney disease.
Great, thank you. We are here to answer your questions. please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hawk. Last week, the CDC reported that a person in a Missouri hospital had tested positive for bird flu. Dr. Hawkinson, there's not a lot of information publicly available on this, but based on little that we do know, what stands out?
Yeah, I think that's exactly right. We do understand that this person was hospitalized in late August, so they are not currently in the hospital. They did recover. What we know is that this was a person that went to the hospital for one reason or another. I don't know if it was for respiratory, typical flu-like symptoms, or for something else, and happened to be tested as well. We do know that there was typing of the influenza. It was an influenza A, which is the bird flu. But then we have to go to what type. So for humans, typically we see during the influenza seasons, it's H1N1 or H3N2 in the most recent influenza seasons. What they did was they must have typed this as influenza A. I suspect they couldn't get a full read at the facility on what specific influenza A type, and so it was probably sent off to the state where they probably tested it and it came up H5. We are still waiting for the N type, but most likely I think most people are concerned that this is the bird flu, the highly pathogenic avian influenza that is circulating in all of the dairy herds, the poultry farms, and in wild birds, as well as other wild animals around the country at this point in time. We know that there are a lot of outbreaks, and there are a lot of those dairy herds. 197 outbreaks in 14 states, actually. But most importantly is this human case is interesting because there was no known contact or exposure to other infected animals, such as infected birds or infected cows, from what the press release says. So again, we should note that this is an H5N1 influenza A virus, and the current outbreak that is in all the dairy herds is H5N1 clade 2.3.4.4b. That doesn't mean a lot to most people, but what it does is help to solidify, is this part of something that we've already been seeing around the country, or is this something new? So again, we know that there's a lot of bird farms, wild birds, wild animals, and also dairy farms that have been infected. So we are trying to figure out exactly where this exposure came from. Again, we know that we have had other humans that have been diagnosed with this infection, but again, most all of them have risk factors with exposure to work, whether it's at those poultry farms or those dairy farms as well. We would also say that this is not new. We should understand that really since 1997, we have seen human infections with H5N1. From 2003 to 2024, there have been 890 human cases of this H5N1 influenza virus infection. So over that span of time, that isn't a whole lot. We know that there really hasn't been any specific sustained human-to-human transmission. There has been very little human-to-human transmission. I think that is vitally important because now entering into typical influenza season with other respiratory viruses, everybody coming off the pandemic at this point in time as well, people are probably a little bit gun shy of, is there going to be another pandemic with avian influenza? We don't believe that the risk is high, but the risk is always there, and certainly that's why we need these good public health infrastructure to help do the testing and understand, how did this virus get to this person, and what is the risk of it becoming a full-blown epidemic or outbreak among humans with human-to-human sustained transmission. Right now, that is not the case. Most people are extremely low risk to have this infection, but of course those people who work in the farm industry, especially with poultry and dairy herds, are most at risk. But again, we do know that these animals do come in contact with other animals, whether it's wild animals coming into contact with farm-raised animals. We know that other mammals have been infected, and there's good data to support the fact that the other mammals have been affected. We have a USDA up-to-date map right now just showing, if you can see on the far right, there is the column showing all of the different type of mammals, genus and species that have been known to be infected with H5N1. They have different, again, wild animals, but also in there they have domestic cats as well. So we do know that humans come into contact with a variety of different animals, whether it's domesticated animals or wild animals as well. There could have been some exposure there. We are waiting to hear the exact risk factor that this patient may have had. Also the symptoms and why they presented as well. If you remember, the other cases of H5N1 that have presented really were not dealing with respiratory disease, but a lot of those patients just had some red eyes with some drainage, what we call conjunctivitis. And so they were tested and found to have influenza H5N1 that way. So it's really unclear exactly how this Missouri patient came to be known to have H5N1 and why did they go to the hospital? Was it for respiratory or other types of symptoms, or was it for something completely different? And we know, Sean, that we have seen that with COVID. We know that people present to the hospital for completely different reasons, but may complain of a symptom and get tested and be positive. So that's where we're at with H5N1. Certainly, if we learn more about this Missouri resident, or if we understand that there may be more increased risk to the general public, we'll certainly keep you informed.
So, it gets confusing, right? You have H5N1, H1N2. It means it's something to us, maybe to you more than me. But it gets confusing, and I know you mentioned some of the folks might be at risk. Who else is at risk, and how do you prevent it? Is it immunosuppressed folks? Anything that they should be looking out for?
Yeah, so for right now, for H5N1, the highly pathogenic avian influenza, again, for the general public, the official statements from the CDC and other state health departments are really that the general public is at very low risk. I think we still would like to elucidate or learn why this patient got infected and what their exposure was, but for the general public, for H5N1, the risk remains very, very low. But who would be at risk for more severe disease? I think that's a great question. It is those people, older age has always proven to be an increased risk factor. Those people with chronic comorbid conditions, especially heart disease, lung disease, kidney disease as well. And those people that are immunosuppressed, I think you're exactly right, Sean. So we need to understand that not just for H5N1, but for really all these respiratory viruses that now will probably have an increased rate of circulation as we get into these winter months. All of those people will be at risk, so it is vitally important to stay up to date with the available vaccines, most notably for COVID-19, for influenza, and for RSV.
Right, thanks. So switching gears a little bit, but still staying inside infectious disease.
Yeah.
How about COVID and this summer wave of cases that we just went through?
Yeah, again, we know that all of these, the data are lagging a little bit, but we do have some graphs, and we have seen that the early indicators, so test positivity, if you remember the last few weeks, it's really been up to that 18-20%. That's that box on the left there. The test positivity is starting to come down a little bit. I think most notably and most importantly is we're seeing that percentage of emergency visits for COVID-19 is starting to drop. For the last month or more, it has been at 2.5% or so. But what we've seen is that it has started to drop a little bit. So I think that is good news. I think maybe anecdotally people are not recognizing it in their friends and family group as far as testing positive over the last week or two compared to the previous 4 or 6 weeks. So that is good news as well. We also do have a slight improvement in the hospitalization rate over the last couple weeks, and deaths are certainly increased still, but we know deaths have always lagged behind the other early indicators, as those are more late-term effects as well. And then, of course, the wastewater, we have shown this and gone to this a lot. I think it's good to be consistent. What we have shown is that nationally, which is the black bar, and most all the other regions, the wastewater isolation or picking up of the SARS-CoV-2 virus is decreased. nationally and those other regions. In the Midwest, it's still a little bit high and kind of an up or plateau trend, but overall, I think we are seeing the kind of end of the summer surge. Hopefully there will continue to be a decrease in the amount of people who are having symptoms and testing positive, and again, going to the emergency department or the hospital for evaluation for COVID. But we should continue to be vigilant and understand that if you've had COVID recently, it is going to be reasonable to wait 90 days, 3 months before you get that updated COVID vaccine.
Right. Thanks, Dr. Hawkinson.
Yeah.
Certainly sounds like as people went back to school or maybe go to some Chiefs and Royals games and started gathering, things picked up a little bit. So.
I think so, but hopefully it's starting to cool down now. We can have everybody healthy and getting back to their normal duties.
Right.
Yeah.
We know many of you have questions, so let's head to Studio B with Alexis Del Cid.
Good morning. I have a great question from Yen Liang. Yen wants to know, could the anti-rejection medications taken after a kidney transplant cause changes in cognitive function?
Great question.
Yeah, great question. So it's hard to say because there's so many things happening with transplant, but we did look at cerebral blood flow before and after transplant. And yes, there is, I would say, a slight decline in the cerebral blood flow, but then overall change in the cerebral blood flow is better. So yes, some of the immunosuppressant medications we administer after transplant, like Prograf is a common one, or tacrolimus, they're known to be they're vasoconstrictors, meaning that they constrict blood vessels, and that can impact cerebral blood flow, and cerebral blood flow in theory can impact cognition. High levels of that medication you actually see those cognitive changes. But it's an excellent question. More work needs to be done here.
Yeah, great. Yeah, certainly we see a lot of those effects when it gets a little bit too high.
Yes.
That's for sure.
Jeremy Yenser has a question. He writes, knowing the connection between kidney disease and brain health, does that mean kidney disease can be a contributor or worsen Alzheimer's or dementia?
Wow, another great question. So kidney disease and Alzheimer's disease. So Alzheimer's disease can happen in some people, and those people can have kidney disease too. But when you have cognitive impairment, when you have clinical symptoms and you have kidney disease, to diagnose whether you have Alzheimer's or not is a very tricky situation, because we talked about how toxins build up in the body because kidneys are not able to get rid of them. Some of the blood biomarkers we use to detect Alzheimer's disease also build up in the body when you have kidney disease, and they'll be high, indicating that you might have Alzheimer's, but you may not have Alzheimer's. So yes, people with kidney disease can have Alzheimer's disease, but the usual tests which are done to diagnose Alzheimer's disease are not very accurate in people with kidney disease.
I actually have a question to piggyback on that question. My dad has Alzheimer's, and what we've noticed over the years is that when he takes a big dip and it has those extra confused episodes, he always has a UTI. We know now to get him tested for a UTI or a kidney infection. Is that related to what we're talking about right now, or is that a separate thing?
Related and separate. So,
okay.
So I guess there's a threshold. So if you have some issues, some brain health issues, it's not, the brain on imaging is not perfect, then you have a lower threshold to have confusion episodes. So the Alzheimer's disease could, or whatever the cause for cognitive impairment is, could lead to those acute episodes. Now, if there is a perfectly healthy brain, if you had one of those, then maybe those UTI episodes would not cause that acute change in symptoms. So I think it's the chronic process, the underlying chronic process, which makes the acute infection present this way.
Interesting. And Marie has a question. Marie wants to know, if this is the case with kidneys, could problems with other organs mimic dementia or Alzheimer's?
Yes. Liver disease is another one.
Wow.
Yeah, so with liver disease, there's obvious, we call hepatic encephalopathy is the term we use. It presents in a little bit different way, but it's there. Heart disease, cancer, chemo brain with chemotherapy. There's a lot of other medical problems which can also affect brain health and cognitive function.
We have a question for Dr. Hawkinson. Dr. Hawkinson, we have a viewer who wants to know, Marcia wants to know, should older patients get the super flu shot instead of the regular flu shot? And can you explain the super flu shot?
Yeah, I think that is just the high dose, and certainly if you are of older age, I think it's 65 and above, it is recommended to get the high dose influenza vaccine. We would certainly recommend it. We give that to our patients as well. So would certainly recommend that rather than the typical other just normal formulation. And basically what that means is just a higher amount of antigen that will just hopefully help to improve that immune response. But again, that is recommended for the older group patients, and we certainly recommend it and give it to our patients.
Well, this has been a great discussion. I'm grateful to our guests for being here, as well as to Tammy Bunny, who couldn't be here with us today, but sharing her thoughts on the video. So I do want to get some final thoughts before we go. And Dr. Gupta, anything you'd like to tell the audience?
Sure. First of all, thank you, Tammy. Then, cognitive function with kidney transplant and other issues, with kidney disease and other issues with kidney disease, the good thing is it is potentially reversible. So I would say there's hope, and I think we're just beginning to understand what this is. And I think stay tuned. In the next 5-10 years, there'll be more. We are currently doing a study looking at some of the symptoms of kidney disease, which may be important to the patients, like depression, physical function, fall risk, frailty. They all go with kidney disease, but we're trying to see the natural history of these symptoms and see where we can intervene to prevent them or to prevent them from getting worse. So yeah, there'll be a lot more to come in the next 10-20 years, I hope.
Great, thank you. Dr. Hawkinson?
Yeah, well, I don't know if the kidney is the brain of the abdomen, is the liver the heart of the abdomen, or is it just the liver of the abdomen? I don't know. Either way, we know that's one of your favorite organs, Dr. Coomer. So yeah, I think this was a good discussion, and I think there was a good question there. Again, it is recommended to be up to date with your vaccines, especially if you're in the older categories, 60 and above, you should be getting the RSV vaccine. Right now, the recommendation is just to get one. We know that the first year that the RSV vaccine was out for adults was last year, so if you received it last year, you should be good. We will rate further recommendations on that in subsequent respiratory viral seasons, but right now, if you are recommended to get the RSV vaccine and have not received it, you should get that dose. Also, very important for influenza vaccine. Right now, overall influenza activity in the United States is low. We never want to miss an opportunity to vaccinate, but if you have frequent visits with your medical care providers or have easy access to vaccines, it may be reasonable to wait a little bit until we start seeing higher circulation of the virus so that you can have good influenza immunity throughout the respiratory viral season. And then, of course, be up to date with your COVID-19 vaccines as well. Right now, as far as H5N1, again, the general public is at very, very low risk to getting that. There is no recommendation for H5N1 vaccination at this point in time. The United States does have a stockpile which they are holding, but there is no recommendation to get that. And again, the general public is at very low risk of coming into contact with this virus or getting infected. But we will keep you up to date as things change, and certainly if we know more about this local Missouri resident and their clinical course with H5N1 as well. So just kind of stay tuned.
Well, we learned a lot today, and thanks for tuning in. Please, if things come up, please don't hesitate to reach out to us here, the Medical News Network, or your primary care physician with questions, and we'll be glad to set you up with anybody if we can. Thanks again to Dr. Gupta, Doc Hawk, and especially Tammy Bunny for letting us share her story. Have a great day.
An infectious giggle and beautiful eyes. You would never guess the trouble that surrounded this little girl's birth for her mom. I'm Alexis Del Cid. On the next All Things Heart, pregnancy-induced heart failure.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.